Good morning. I'm not as funny as Brian Feely. I'm not going to try any jokes either. So we're going to talk today about lumbar spine injuries in athletes of all ages. And as Carlin said, I joined the team 3 years ago. I have a clinic here in the city at Mission Bay at UCSF, and I also work with children over in the East Bay at Jones Hospital, UCSF Benioff Jones Hospital in Oakland and Walnut Creek, and I still do work with athletes at UC Berkeley. I have no disclosures. And so our objectives today are to understand how an effective history and physical exam can lead you to a focused differential diagnosis for low back pain. Let's try to clear up the mystery of someone who comes in and says, my back hurts. Develop treatment plans for the most common causes of low back pain in your athlete population. So important points that I'd like to start off with is with a good history, what you learned in your training. You should arrive at the correct diagnosis about 90% of the time. It should be able to lead you to what you think about before you start that exam. And at least you'll get a confident differential diagnosis. With a good history and a comfortable knowledge of even basic anatomy, it will make your exam focused, quick, and efficient. And it'll give you more time to chart because we all need more time to chart. And with a good history, comfortable knowledge of basic anatomy, you won't need to palpate till the end of the exam. And I know I teach medical students now as well at the JMP program, and the fact is that a lot of the things that you learn about, it says observe, palpate. And I like to wait till the end because if you palpate and you make them hurt, all bets are off in terms of how much they're going to let you do. So some exam room tips. Stock gown, sheets, shorts. I like people with low back pain to be in shorts. Be able to get to both sides of the exam table. Because think about that table there. Here, if you're going to be examining someone with low back pain, you're either going to reach across and hurt yourself, or you're going to make them spin, and that's not going to be very comfortable for them either. So I recommend a table that you can get to either side, and then this will slide out as well. And have a step stool handy for you to be able to get up and examine them nicely and without harming yourself. So you can ask, how many of you guys think about the OPQRST type of questions when you ask for someone that comes in with a pain? Right, that's one way that you can do it, and this is what I like to go through. Certainly you know their age, whether or not they're involved in a sport or activity, their occupation. You ask for the onset, that's the O. What's the injury mechanism? Is it acute or chronic? Could they continue activity? Or, what was the precipitating activity? And then mechanical symptoms, locking, tightness, weakness, swelling, etc. Any changes in bowel or bladder? And then you get to the symptoms of the pain, numbness, tingling. This is where that location, where's the pain? Q, quality of the pain, radiation, severity, timing. When does it happen? And then other factors, and that's where the P comes in. What provokes it? What palliates it, right? What makes it better? What makes it worse? These are all questions that we should ask. The other way we can do it is old carts. Have you guys ever heard of that? Mnemonic in terms of asking about it. Onset, location, duration, character, aggravating, alleviating, right? Radiation, timing, severity. This actually gets a lot of those answers in. Whatever you use or however your pattern is, these questions need to be asked. So red flags, these are common things, right? We ask these because we want to make sure, number one, there's no systemic cause of the low back pain. Number two, if it's worsening, we want to make sure that they're going to get to the ER right away. So these are the ones, right, that we typically ask. And then actually, for those of us, history of cancer is probably the most definitive reason of having a metastatic or a cancer as a cause. And that's what we always worry about, right? We worry about IV drug use, steroid use, etc. But history of cancer is number one in terms of that, in terms of having a metastatic disease or cancer as a cause of low back pain. And when we talk about this saddle anesthesia, numbness in the groin, loss of bowel or bladder function, we can see why this cauda equina syndrome, why that happens, is because of the pressure on the roots that go down to the control of the bowel and bladder. it's very interesting because when you ask these questions, you have to know your patient population as well. And one of my medical students just yesterday said, well, you know, she was doing some history taking, and she's like, well, how do you ask about numbness in this area with a patient? And how I say is, when you wipe after you're done using the bathroom, does that feel differently to you? You know, I mean, that's just one of the ways that you can do it. Okay. So quickly, anatomy. We start with the inner layer, right? This is the basic layer, the bones, the joints, and the discs. And so becoming familiar at least with the fact that these are the SI joints and being able to palpate it, right? These are the spinous processes. In between every vertebrae is a disc here, you know, formed of the annulus fibrosus and then nucleus pulposus. And so this is like a bunch of rubber bands that are keeping this together and forming a structure to this gel bouncy house, which helps absorb shock, but also adds stability to the vertebrae. In between are the intervertebral foramen, where the nerve roots come out, okay? And then there's your spinal cord. So this is what stabilizes the spine, is that lower level. Then we get to, at the level of the pediatric, one of the things to remember when we're dealing with kids and adolescents is they have more ligamentous laxity, they have greater mobility of their spine, their spinal columns are actually more elastic than the spinal cord. And there are immature joints and there's ossification centers. So when we talk about that, we've got to keep that in mind when we're talking at kids with low back pain in terms of structurally what could be going on with them. And then the nerves. There's 31 pairs of nerves, and when we're remembering, the C7 nerve exits between the 6th and 7th cervical vertebrae because we have a C8 nerve. Then that jumps in, and then that changes the exits of the nerves. So higher up in the cervical spine, your nerve number is going to be above the vertebrae. Then from the thoracic and lumbar down, your nerve number is going to be below its vertebrae, okay? And then you can see that we've got the sciatic nerve down here, and then we have the plexus of the femoral nerve anterior to the hip. Dermatomes. Dermatomes are pretty important, and myotomes, because it helps us determine where there's going to be a source of weakness, et cetera, what we're dealing with. So if we look at dermatomes here, that's a sensory pattern, you can see that. And if we look at myotomes, these are the common nerve roots, and you can just test these to test whether or not we're looking at the lumbar 1 or 2 nerve root, 3 or 4 is knee extension, 4 is ankle dorsiflexion, 5 is great toe dorsiflexion, S1 is ankle plantar flexion. Boom, you test those, we're golden. Okay? However, dermatomes can be a little bit different if you look at different maps and patterns. And Lee looked at it and found that, boy, there was a wide range of dermatoma patterns that had been evaluated and documented in literature in the past. But if you look at a standard area of where we can check what's standard here. L5 is going to be right at the dorsal interspace, the first and second, between the great toe and the second toe, right? S1, what looks common from S1? Lateral foot, okay? L4, medial malleolus. Because if you look here at this dermatome, the anterior knee, this one says it's L3, right? So look at the common dermatomes as you check. All right, and then the muscles. We've got your superficial group, and you have your deep group. And you remember this mnemonic, I don't know if you guys remember, I love sushi. I say that now. It was different when I was in medical school. But you've got these. Here's your longissimus thoracic. It's amazing how many back muscles there are supporting the spine. Superficial muscles and deep muscles, okay? And muscle strain is a pretty common cause of nonspecific type of back pain. Don't forget these muscles. This is the psoas muscle, which starts on the spine, and the iliacus muscle, which is on the anterior aspect of the iliac crest, and they come down together to form a large major hip flexor, the iliopsoas. So we talk about the hip flexor iliopsoas, look where it starts from. We oftentimes forget that. It starts in the spine, and it creates a lot of back pain. And then in the back, You've got your glute, you have your quadratus lumborum, and then again, your rector muscles. Okay, so systematic exam that I like to do, observation. I look for any abrasions, etc. Then I move on to sitting, where I check reflexes, sensation strength. I do a slump test. Supine exam, I lie them down. I do a straight leg raise. I check their hip range of motion, hamstring tightness, which can contribute to back pain. And then I palpate, at that point, the LS spine, SI joints. I can do a femoral nerve stretch test. We're going to talk about some of this, and we'll see this on the exam later. And then standing, I'll do range of motion as they can tolerate, and then some other special tests. Always do a heel walk and a toe walk. Okay, so let's start. Oh, and then I wanted to tell you, common lumbar spine injuries in athletes when we're looking at kids and we're looking at adults. Younger, common causes are mechanical low back pain, spondylolysis, spondylolisthesis, and a herniated disc. And the older, we're also looking at mechanical back pain or lumbosacral strain, herniated disc, and degenerative discs. All right, let's do the fun cases here. Case number 1. This is the injury. This is at World Cup in Brazil. All right, 22-year-old professional soccer player. Date of symptom, it was acute injury. We just saw it happen, right? What was the mechanism? Direct blow. Were you able to continue playing? No. What are the symptoms? Tightness in the back? Nope. No problems with bowel or bladder function. You can observe that there's some swelling at the site of the trauma. Okay? Still history. Pain. Location, left lumbar spine. Quality of pain is sharp. Radiation to the left buttocks area. Severity, 13 out of 10. Timing, constant. Any change in position, pain. Modifying factors, no previous injury, surgery, best when lying still. Okay? That's a palliative question, right? Okay. Observation, obvious discomfort. Sitting, local pain with a slump test, no radiation, normal reflexes, strength and sensation. Supine, negative straight leg raise, full range of motion of the hip, no pain, prone, tenderness, left lumbar spine, L3, L4 levels, standing, range of motion, pain in all ranges, pain with walking. Am I going too fast? Is this good? Okay. Here's some parts of the exam. This is a slump test. So what I'll do is, while they're sitting, I will have them raise their leg, dorsiflex their foot, then chin to the chest and have them lean forward. This is like a straight leg raise, but they're sitting. So I like to do this to get a sense of, number one, how sore that, whether or not I can see there's any radicular component. I also do this because some lingerers that may be in your office know about the straight leg raise. And they were going to go, ouch, yeah, I got pain down my leg. They don't really know about this test, okay? The other thing that I'll do is if they put their hands back into a tripod position, it's either because they're having really acute pain or they're getting radicular pain or their hamstrings are tight. So I just kind of like that test. This is the straight legs raise that we're all used to, right? And then saying, yes, they've got pain down their leg at however many degrees, 35, 45, etc. Okay, so these are his x-rays. I hope we can see them. So this is the transverse process. And you can see that there's a fracture through here and here. If there's any suspicion or there's a lot of bowel gas or you suspect an acute vertebral fracture from trauma, you can get a CT scan where you can see that. So diagnosis is the left. These weren't actually his x-rays, but his diagnosis is that left L3 transverse process fracture. And it's happened in many of our professional athletes that you've heard about. Happened in a car accident, Cam Newton, ended Tony Romo's career, and this hyperflexion injury happened recently in Derek Carr. So you can see that here's the transverse process. Protection-wise, there's a lot of muscles that help protect it, but that type of injury, because there's muscles that attach, there's a pull, and so you can see how you can fracture that transverse process. So majority is treated conservatively, and there's no surgery that's needed for this. Stabilization is not needed unless they're, in distress or they need a brace for a short time period. And there's a gradual introduction of movement and PT and rehab. How many of you guys know how long was Derek Carr out after he had this transverse process fracture? 2 weeks. Full return to activity expected. And so here he is for Brazil playing in the Olympics and winning a gold medal. Okay, case number 2. We've got a 50-year-old overweight female carpenter. Date of injury, 2 days ago, she was playing volleyball at a family reunion, and as she was reaching for a ball, she had pain. Stiffness, no weakness, no problems with bowel or bladder. Okay, you guys get this pattern of how we're asking. Location, the entire low back hurts. Burning quality of pain, no radiation, severity is 4 out of 10. No night pain, definitely worse with motion. Other factors, better with ice, ibuprofen, knees to the chest, no red flags. Okay? Observations, she's stiff, she's got discomfort with movement, negative slump, normal reflexes, sensation, strength. Negative straight leg raise, hip full of range of motion without pain, prone, no bony pain, tender bilateral paraspinal muscles, negative femoral nerve stretch test, ham glutes, maximum strength, glute max, strength is 5 out of 5. So her strength testing is good. Standing, stiff pain with forward flexion with spasm, pain when returning to the erect position, very slow gait. She can walk on her heels and on her toes. Okay. Here's her exam, parts of her exam that I want to demonstrate. So again, this is a straight leg raise. And what I'm going to show you later on is if you get to a certain degree and they say, I feel radicular pain down into my calf, then lower it until she doesn't feel the pain anymore, and then dorsiflex the ankle to see if it returns. This is a good provocative test to see if it's radicular. Now, in this case, she didn't have it, but I want you guys to know about this test because it's very helpful to really confirm that it is a radicular source. So again, you elevate it until your patient has leg pain. Then you say, I'm going to lower until you don't feel the pain anymore, or you don't feel the tingling into your toe. And then once you lower it, and then they say, nope, no more pain, then dorsiflex again and see whether or not that returns. Does that make sense? If it's coming down the leg, the sciatic nerve, if you stretch it, that's going to be recurrence. This is the femoral nerve stretch test. Okay, you have them prone, and you can see you're doing, I'm going to try to give you guys equal time. You can see that, again, the femoral nerve goes anterior, but then what you're doing is that you're trying to stretch the femoral nerve in this position, and you want to see whether or not they have radicular pain down the anterior thigh. Okay? So not down the posterior aspect of the leg, but down the anterior aspect of the leg. How many of you guys have done the femoral nerve stretch test? Okay, good. Okay, so her diagnosis, no radicular pain, right? Pain is localized, not radiating, is a muscle strain. 90% of back pain that we're going to see is muscle strain in our office. Acute sudden movement or action, overuse from poor posture, muscle strength, endurance, usually common, very common and self-limiting. Treatment, heat, ice, proper posture, proper movement patterns, active daily exercise. If they can walk, please do so in proper footwear. PT manipulation, massage, acupuncture, studies have shown minimal benefit after 2 weeks. And then nonsteroidals, muscle relaxants, and weight management. So these all have studies, and this is a great review article that I have listed on here, but these are all really good things to consider. Nonsteroidals, good. Muscle relaxant, good for function, not so much for pain. Nonsteroidals, good for both. And weight management, you heard Dr. Feely speak, excellent for this problem. Okay, now she's 51. She's less overweight. She's still a carpenter. She has started working out in a gym. And she comes in because 2 months ago, she began to have pain. 3 months ago, she joined a gym, and they began doing medicine ball abdominal workouts, okay, twisting, all right? She began increasing her running mileage on a treadmill. And after a month of doing this program, she began to have pain, okay? Stiff, she's weak. She says her bowel and bladder are okay. Where's the pain located? Lower back, low left buttocks. She's got achy pain even at night, sharp and burning during the day. It does radiate outer leg to her toes. This is a little bit different than the handout if you want to change it or make notes, but it's okay. Don't worry about it. Severity, worsening, 8 out of 10. Timing, as above, right, with the quality, what we mentioned. Ice, heat, non-steroidals will temporarily help. She's got a decreased appetite, just doesn't feel hungry, not sure if it's because she's not working out anymore, and it hurts with coughing and sneezing. Okay, are you guys with this history thinking about a differential diagnosis? Thinking about what you're going to examine, what you're going to look for? Nod. Okay. Observation, she's standing when you enter the room. She doesn't want to sit down. Hurts too much. Okay? You make her sit because you're mean. Positive slump test. She's got a decreased sensation in the first web space. Her strength is decreased, 4 out of 5 for left great toe dorsiflexion. Okay? Start thinking about the nerve root here. That was your dermatomas and your myotomas that you were testing. Supine, left leg straight leg raise, positive at 45 degrees. Left hip, full range of motion, but some pain down her leg with external rotation. She's tender on palpation when she's prone at the L4-5 level more than the L5-S1. She's tender along the left SI joint. She's got a negative femoral nerve stretch test. No pain going down the front of her thigh. And she's weak in her hamstring and her glute, and you can't get an L5 reflex. Okay? So, standing, she really can't bend past 45 degrees. Right side bend is also painful for her. She's able to toe walk. It's harder for her to heel walk. And she can do 22 heel raises on the right and 16 on the left before she cramps up, and there's no atrophy of her muscles. Okay, L5 reflex. You guys are pretty comfortable testing the L4 and the S1, right? The L5 is a little bit harder to do, and the easiest way to do it is you can test it prone or you can test it sideline, okay? And we'll demonstrate that. But you put the finger on one of the biceps femoris or the medial hamstring, and then you use a reflex hammer. Okay, look at the disc and nerve root relationship on this case. Remember we talked about how the nerve root comes underneath the vertebrae, okay? So L4 comes underneath, the nerve root comes under the L4 vertebrae. But look at how the nerve roots actually come down. So even though there's a nerve root coming out here, there's other nerve roots that are traveling down to come out later. So the reason I bring this up is because there's a disc and nerve root relationship. Depending on where the disc is located, if there's a disc injury in relationship to the nerve root, will be whether or not you get radicular pain. So for example, this is a very lateral herniation of the disc on the very left-hand view. So if the person's going to lean right, they're not going to get any radicular pain. However, if they lean left, there's going to be compression there of the nerve root. On the other hand, if that disc herniation is more posterior, not so lateral but more posterior, then you can see that if you lean right, there's going to be compression and radicular pain as opposed to when they lean left. Okay? So it really depends on where the disc is in terms of that radicular pain. Just document it as you do your exam. So in this case for imaging, you can see if you do a plain film, there's basically less space between the L4 and L5 vertebrae, and you can see that there's many different causes of disc problems, including, this is a normal disc, but degeneration, bulging, a herniated disc, which goes right into the foramen, a thinning disc, and then disc degeneration with osteophyte formation. So in this case, again, with an MRI, you can see where there's a disc bulge, And you can also see where there's a disc herniation as well, and that's more lateral with an MRI. So in this diagnosis, it's an L4-5 disc herniation, okay? So with an L4-5 disc herniation here, the L4 nerve root's not affected, but it's the 5 that's coming through, and this is where you get the pain, radicular pain on the outside of the leg, the numbness here, right? The weakness in heel walking, as opposed to if the S1 nerve root's being affected here, right? And these are the symptoms that you can get with the decreased reflex, etc. Okay? This is on your handouts. Okay. So again, if there's any weakness or loss of reflexes, you can do a subspecialty referral. Emergent care of loss in bowel and bladder, saddle anesthesia like we talked about, and if it's increasing pain, unresponsive to medications. Physical therapy, posture is important, weight loss again. You can add a nonsteroidal, and what I do with someone who's in pain, I want to try to reduce or give minimal opioid use, but I'll alternate a nonsteroidal with acetaminophen every 3 hours. And then other meds are individualized, and again, this study is really good, but you'll look at prednisone. Prednisone as an anti-inflammatory can help with pain. There's studies that show that it does. Some studies show that it does not. Tricyclics, narcotics, gabapentin. Actually, if you look at different back studies, some people don't even recommend tricyclics or gabapentin for this type of pain. If you remember here, the lumbar intradiscal pressures, this study is classic. A study done in 1966. I can't see, but I think it's 1966. Yes. With catheters placed into disc, and you can see that the less pressures in the disc are when the person is supine, knees up, supine, standing. Look at what we do every day. Well, not necessarily us because we're moving around, but our average worker now is sitting, and our average child in the classroom is sitting all the time. Their intradiscal pressures are higher. So the ability to be able to move around, get a standing desk, be able to stand in the back of a classroom if they're having disc problems is really, really important. Okay, case 4, history. 30-year-old male programmer training for the marathon. Onset of pain. Off and on for 2 months. Didn't really want to come in. I don't know what caused it. I was doing some interval training where I was sprinting more. Maybe that's what caused it. It got more sore when I was done with that. Okay? Jogging versus sprinting. Think about that. Tightness in the left hamstring and the left lower back. So, location, proximal hamstring, and the butt. Sharp, achy. Radiation, nope. Pain, I don't know. Sometimes I don't have any pain at all. Sometimes it gets to be minimal, 3 out of 10. Intermittent, I never have night pain. What are the other factors? Well, you know, I've got a big project I'm working on. I've been working longer hours where I've been sitting, and I haven't been able to stretch as much as I normally do. Okay, no discomfort when you look at this patient. Negative slump test, everything looks good strength-wise, reflexes, negative straight leg raise. Positive Thomas test on the left. Who knows what a Thomas test is? Okay, we're going to learn, everyone. Prone, tender at the left SI joint, not really tender over the tendon where he says he feels the pain. No pain with passive hip extension. And standing, tightness in the proximal hamstring when he leans forward. Positive Gillet's test on the left. Gait is normal. Okay. This is the Thomas test. This is one of the easiest things that I do with all of my patients. I have them come down to the end of a table. I usually have them come down even further than this diagram depicts, and I have them pull their knee up to their chest, make sure their back is flat to the bed, not arched but flat, and then I see whether or not their hip flexor is level with the table and the angle here of their knee. If they're flexible in both their iliopsoas and their rectus femoris, it's going to be a 90-degree angle here, okay? So he's a little bit tight through here, but here you see a perfect example of a tight iliopsoas through here and possibly the rectus femoris. So this is called the Thomas test. The other thing I do, who does an Ober test for IT band tightness? Who feels that it's hard to do? Okay? So what I do during my Thomas test is I also stand back here and I see whether or not this leg is abducted. If it's abducted more, then they've got a tight IT band as well. If they're pretty straight, then I'm pretty comfortable with that. And then in this position, I can palpate the IT band as it comes down and see whether or not they're tight or tender, and I can compare both sides. Gillet test. This is where patient is standing. You have your thumbs on the posterior superior iliac spine, and you have them bring their knee up, and you see whether or not they're, the right side or the left side of the nominate bone is going to move. So one thumb is stable, the right knee goes up, and this is a normal test where your thumb is going to go down. It's abnormal if your thumb stays up, which means you're lacking that rotation in that right pelvis. Okay? So remember these muscles. Remember I told you how important the iliacus and the psoas are? What happens is, if they're tight, it's going to tilt the pelvis forward, stretch your abs, but also cause strain on your hip extensors, including your hamstrings. Okay? So this is getting tilted forward because of the tight hip flexors and because then you're putting strain on the hamstring. So conceptualize this. When you're sitting all day, like how you are sitting listening to us talk today, are your hamstrings lengthened or shortened? I mean, are your hip flexors lengthened or shortened? They're shortened, right? So this individual was sitting more and not stretching as much, and then he was doing intervals where he's sprinting. When you're sprinting, what's happening to your hamstrings? They're getting stretched. Whoops, oh, I'm talking into the pointer. Isn't this great? Sorry. I wonder why there was no sound. And so what's happening is you're putting strain on your hamstrings. Okay, diagnosis for this gentleman, left SI joint dysfunction, tight hip flexor, tight IT band, weak glutes. Okay? Excessive stretch on the hamstring and adductors as the femur moves forward, but the pelvis doesn't rotate. You can have posterior rotation as well of the pelvis, okay, because your hip flexors are weak and the back muscles are too strong. So we need to rule out a rheumatological disease if there's a lot of SI joint pain, so especially in your kids, if there's morning stiffness, if there's really great resolution with a nonsteroidal, we've got to make sure we're not dealing with an arthritic condition, okay? And then physical therapy helps with this. Okay, last one. You had a 15-year-old high school football player, right hand dominant, okay? And he's going against big offensive linemen like this guy, all right? Look at their backs. Gradual onset of pain, 2 to 3 months, doesn't really recall, happened during football season. He plays on the line. He's an offensive lineman and a defensive lineman, and he lifts weights as well. Just feels tight. No swelling. Where's the pain? Low back, left-sided, dull to sharp, no radiation, 5 out of 10. And the timing, it hurts during and after activity. It hurts at night too, and he sleeps on his stomach. Other factors? He thinks he's peeing more. Non-steroidals help. 1 week off helped. Okay. Here we go. He moves easily. Here's the exam sitting. We do, right? Costovertebral angle tenderness, and why are we doing that? He talked about he's peeing more. We want to make sure it's not a kidney issue, but he's afebrile. Supine, negative straight leg raise. His hamstrings are tight though. Thomas test is tight bilaterally, tight hip flexors as well. Tender at the L5S1 level, left-sided more than the right. And passive extension of the left hip creates pain when he extends at his back, when he's prone. And standing, pain with left side bend, left rotation extension, and one leg extension, it hurts a lot more on his left side. So what's that look like? So this is how I test for hamstring tightness. I look at the popliteal angle, right through here, and I measure that, okay? I've had patients that have a popliteal angle of 90 degrees. Their hamstrings are so tight, all right? And some people measure this angle. I always measure this one. That's how I learned in my training. This is a active extension of the back. When they're prone, I'll have them push up on their elbows like they're watching TV and then push up. It's an easy way for them to control their extension to see if they have any back pain with it, okay? Rather than them standing and extending. That's a lot more uncomfortable for patients. So I'll do this. And then this is the one-legged standing extension test, where they stand on a leg and then they extend, and then I see whether or not they're hurting more on the right side or the left side. If that makes sense, because all the pressure is through the right side of the column. And then we switch over to the left side. So this individual, you can do x-rays. Okay, remember we take a look at the vertebrae. This is the AP and the lateral. There's not a lot you can see on these films. You can see the discs, spaces. You can look at alignment. You can see facet joints on the AP film. Oblique views show you much more. It shows you the pars interarticularis. And this is called the Scotty dog. Okay, it looks like a Scotty dog with spondylolysis, which is a stress fracture of the neck of the dog, Scotty dog. You can sometimes see this. And in fact, this is another depiction. So this is what makes it up. The facet joints make up the ear, the eyes, transverse process. There's a Scotty's collar when that happens. This is the dog itself. But you can see on this a fracture line. So should we get these? When we have someone with extension-based pain, an adolescent, and you're suspecting a fracture, well, what I'd say to you is this. There's a lot of radiation with x-rays, especially those oblique views. You could get a bone scan, SPECT scan to show it. That's a lot of radiation, especially in an adolescent with a long life to live. You can get thin-cut CTs, okay? That's a lot of radiation in a young athlete with a long life to live, or you can get an MRI. So the MRI in more and more studies are being found to be very, very sensitive for at least early stress reactions, and this is what you'll see on stir sequences. You'll see edema right here in this area pedicle of the pars. So you can also see old fractures and the fresh fractures as well. So we're using MRIs, and if we need to document for some reason, we'll do thin-cut CT just in that area of suspicion that the MRI brings up. So for spondylolysis, consider referral if the positive imaging, because it is still controversial in terms of how we manage this. Depending on how they feel, we may or may not brace. Kids hate this TLSO brace, but we work on physical therapy. We work on tight hip flexors. We make sure that the low back is not hyperextended. We work on flexibility and stabilization. We return to play when pain is free and strong. We do know that if it's bilateral, they have an increased risk of moving on to spondylolisthesis. Anywhere from 45 to 75% will end up with a grade 1 or grade 2 slippage. So management is different if it's bilateral or unilateral. And this is why I'm saying that management is a little bit controversial with bracing. So how to prevent, right? We want to prevent. We're healthcare providers. We want to prevent back pain. Exercise daily. Don't overdo it, right? If you're a gymnast, you know, there's plenty of studies that show that you don't want to train more than your age. So if you're 8 years of age, you don't want to train more than 8 hours a week. And I recently had a gymnast come in my office who was 8. She's training 12 hours a week. Doesn't seem like it's that much, but I'm seeing more and more 8-year-olds with overuse injuries like Achilles tendonitis, and that shouldn't be happening. Practice correct posture. That is so key. You know, lift correctly, and including lifting weights. If they're weightlifting, make sure that they've been instructed properly how to lift weights. A lot of disc injuries in young kids that are weightlifting. Sleep properly. Stomach is probably not a good idea, okay? Avoid prolonged positions, prolonged sitting, That'll create tight hip flexors and achieve and maintain a healthy weight. There's usually not a quick fix, and this is what you need to let your patients know. I like this proverb, tell me and I'll forget. That's what I just did. Hopefully you didn't forget everything. Show me and I may remember. That's what we're about to do. Okay? Involve me and I'll understand. So with that, I'm about to do the show me part, but this part, involve me. We've got a hands-on workshop, how to do the lumbar hip exam a little bit later, and that way you guys will be doing hands-on with each other. So if you want to come to my session, please do. Okay, thank you.